All right, let's go. Hello, everyone, and thanks for joining the impact of your surgical procedure list on case durations and scheduling accuracy. My name is Jordan Leibovitz, and I'm part of the marketing team here at IMO. Before we get started, I want to take care of a few items for those attending. First off, this webinar is being recorded and will be available to you for future viewing. Throughout the session, all attendees will be in listen-only mode, so if you have any questions, please type them into the question section on your GoToWebinar console, and then we'll answer them during Q&A. We'll get to as many questions as we can, but if for any reason yours is not addressed, we'll follow up with you after the presentation. Today we have two presenters, Alex Brown, Perioperative Solutions Specialist at IMO, and Vic Anantha, Chief Product Officer at Caresyntax. So, as mentioned before, if you have any questions or comments while our presenters are speaking, please type them into the questions section on your control panel. And with all of this being said, I'm going to pass it over to Alex.
Thank you, Jordan. So as Jordan said, my name is Alex Brown, and I'm a Perioperative Solutions Specialist here at IMO. Before coming to IMO, I worked for a number of years at Epic on the Uptime module, which is the surgical scheduling and management module at Epic, as a technical services representative. I also worked as a technical coordinator when I was over there. Prior to that, my educational background is that I have both my bachelor's and master's degrees in biomedical engineering from Tulane University. So for those of you who may be not as familiar with IMO, I just want to take a couple of minutes here at the beginning to introduce ourselves. So IMO has been the innovator and the vanguard in clinical terminology within all of the major EMRs for almost 30 years. So we have established partnerships with Epic, Cerner, NextGen, and really all of the major EMR systems. And our industry-leading terminology has been being maintained by an expert team of terminologists that manage over 5 million terms mapped to 36 different code systems. We have over 300 different employees here at IMO, including physicians, terminologists, PhDs, solution specialists such as myself, and we're all here to help manage and curate this clinical terminology that allows us to be the industry leader in this healthcare IT space. So something we've been really focused on as an organization lately is the fact that healthcare has a data problem. As options for care delivery and health tracking have become more complex, sources of patient information have become significantly more abundant. The increasing volume of patient data increases the potential for powerful insights, predictive analytics, reporting tools, but this added complexity across the healthcare ecosystem poses significant challenges for data quality and integrity. All these technology and all these advancements in analytics have seen really great, they're extremely promising and they have great potential. But right now, a lot of it is really struggling to move forward due to poor data quality. And poor data quality can occur for several different reasons. One, data capture at the point of care can be extremely cumbersome in different EMRs and different lab systems and in other healthcare IT spaces. And then aggregating that data and moving that data throughout your system at your organization can introduce critical gaps and inconsistencies. An example of this is secondary CPT codes. Secondary codes. Secondary codes in some systems may drop out when the information gets moved into them. At the end of the day, this leads to missing data in the data warehouse, which in turn can lead to uninformed decisions. And so at IMO, we've really been focused on being a healthcare data enablement company. And we really look at addressing this across the entire ecosystem in your organization, looking at point of care workflow solutions that make it easy to document appropriately and document the way a clinician would like things to be documented, and then data quality management solutions that can help fill in those critical gaps that get introduced throughout this process. So today, what we're really here to talk about is surgical data and surgical data management related to the procedure list and how that can affect things like financials and case duration accuracy. So before we get to dive too deep, I do want to give some definitions. When I talk today about the surgical dictionary and the surgical procedure list, what I'm talking about is the list of procedures that an organization does at their site built into the EMR. What this usually consists of is a corpus of terminology with a procedure description that is supposed to be clinically representative of what is going on in the OR, combined potentially with one or more codes, typically CPT codes, that are attached to that terminology. Now, the exact structure of that is going to depend on your EMR, your surgical scheduling system. But that is the typical setup in most of the major surgical EMRs. Now, this list is standardized, is custom to each organization because it needs to represent the surgeries that they do. Therefore, it's generally managed and maintained by the organization itself. And different end users with varying needs are all going to rely on the content stored in the surgical scheduling dictionary. An example of this is the OR scheduler, when they go to schedule a case, needs to be able to find the appropriate procedure that the surgeon would like to perform in order to get the case scheduled. And the surgeon themselves will often needs to be able to find the CPT code that they want associated with that procedure. And that's also critically important for pre-authorization for your revenue integrity teams, so that they know what CPT codes are likely to be billed. That helps them ensure that Medicare patients and other patients are properly pre-authorized, that they're scheduled in the correct location. And it's also critical on the data integrity side of things, because all of the metrics and all of the data that is recorded throughout the case and throughout the surgery is going to tie back to the procedure that the surgery is initially recorded with, that the surgery is initially documented with. And on the clinical side of things, the schedule and the OR staff, they need to know what resources to book, how long a case is going to take, and what supplies and preference card to pull to make sure they get all the appropriate things in there. All of this starts off by having a clean, standardized set of terminology to describe the procedures at your organization so that they clinically represent what is going on. So what are some of the common issues that we see in procedure lists? Well, one of the most common is missing procedures and services. Another very common one is what we call indistinguishable duplicates. So terms that appear multiple times or multiple terms that are clinically representative of the same surgery. As surgical procedure lists often also contain vague, unspecified terms, which are difficult to determine what their meanings are, or outdated, incorrect, or missing codes that affect pre-authorization processes. Finally, a lot of dictionaries struggle with a naming convention. Naming conventions are important because they make it easier to search for and easier to find the appropriate terms. So here at IMO, we've examined many organization surgical scheduling dictionaries, and we have found that on average, about 3% of the terms in most organization surgical scheduling dictionaries are duplicates. About 22% of the terms are associated with incorrect CPT codes. 75% of the terms are missing appropriate CPT codes, and 2% of the terms are something I really want us to focus on today, which are terms that have too many CPT codes, or what we call overly broad terms. An overly broad term, and we'll go into this a little bit more detail in a few minutes here, is a term that acts kind of as an umbrella term that contains multiple surgeries that can be performed underneath it, where it really should be broken down into more specific terminology. So what are the consequences of these things that we've been talking about so far? Well, some of the consequences are that it can be hard to find the appropriate procedure that you're looking for to search and select when you're making your order, or when the OR scheduler's scheduling the case. This often leads to something we call close enough scheduling. So close enough scheduling occurs when you select a procedure that is similar to the one you actually want to perform, and then you free text over that procedure in order to give it the name that the surgeon would like to do. The issue with that is that the data and the procedure times, preference cards are still all going to be associated with the selected procedure, not the free text procedure. And if that selected procedure is then performed another time, you're going to have data that is not properly associated with it, or that is improperly associated with it. And when you go to record on that, there won't be any way of breaking that out. We also often see incorrect or absent codes on pre-authorization, since these codes do often flow into pre-authorization workflows. Challenges maintaining and selecting the appropriate preference card. And what we're about to dive way deeper into, inaccurate procedure time averages, which can impact things like utilization, room utilization, and other OR metrics. So before we dive any further, we did want to ask an audience poll question, and I believe this should now be popping up on your screens. Currently, what is your most pressing issue stemming from surgical procedure data? Is it the time and resources allocated to manually maintaining that data, whether that be from your IT team or your operations teams? Is it the terminology and data enablement for the perioperative workflows? So how that terminology and how that all flows into your scheduling processes, your preference card processes, and your documentation. Is it the finance and revenue integrity aspects of this? So how that all flows into denials, how that flows into pre-authorization, or is it OR specific reporting analytics? How that terminology ties to properly recording your metrics. So if you could just take a minute to address the poll, we would appreciate that. Okay, so I can see here that the poll is now closed. And I see that about 43% of you responded that terminology and data enablement for perioperative services is the biggest problem that you guys are seeing. 29% of you are saying time and resources allocated to manually identifying these. And 29% of you as well said OR specific reporting and analytics. Okay, that's very interesting. And it's interesting to see how different the responses are. So what we're going to dive into a little bit deeper now is case duration accuracy and procedure time averaging. So for some background, typically most EHRs and surgical scheduling tools reference procedure names and or the associated codes that a surgery is scheduled with to calculate a moving average of the time a particular type of case takes. Oftentimes this is going to look at your wheels in, wheels out time. That's pretty common, but it may also look at different times for every procedure that's associated within the case. Moving forward, the system may then pre-populate this average as a default option for the OR scheduler to reserve on the block schedule. And that's what we call procedure time averaging. It's a pretty basic calculation. Oftentimes it looks to the last 10 times that a case is performed by a specific surgeon in a specific location. But these setups may be different depending on your surgical scheduling system and options within that system for you to pick. So the idea there though is that we want to know how well is that working? How well are we doing at properly estimating how long each one of our surgeries is going to take? And we can figure that out using case duration accuracy metrics. So case duration accuracy metrics are defined by the number of cases completed within a defined range, oftentimes 15 minutes plus or minus, but it can be whatever works well for your organization, over the total number of cases. An example of that would be if half of all procedures in a given time frame deviate less than 15 minutes from their estimated end time, your case duration accuracy would be 50%. So we're really trying to use it as a metric to clinically to represent the frequency at which the OR completes all of its procedures on time. Now this can be off because something went wrong in the OR and the case ran long. The case just happened to finish up early that day. But a lot of times the reason why organizations see low case duration accuracy metrics is that they're not able to properly estimate how long a surgery is going to take. So why does this matter? Well, one, inherent variability and unknowns of surgical procedures can impact the durations and complications during the surgical scheduling process. The duration of the procedure is really critical to understanding how to optimize your schedule, how to reduce delays for patients, for providers, as well as reducing overtime and underutilization of operating rooms for the administration. So you need to have these accurate time estimates to operationally improve utilization, reduce your costs, and identify any surgeries that might be considered outliers. So how is this affected by terminology? Well, in many instances, a surgical dictionary may have only one procedure name that is used for every variation of that surgery. We're going to dive a little bit deeper into this example of lymphadenectomy, but this is one where we could call it out, where this is a very broad procedure term that really doesn't represent clinically what is going on in the OR. Many different cases are entirely unique, and they may require different amounts of time, not to mention different room setup, equipment, supplies, depending on the location of the surgery, depending on the equipment that's being used, depending on the approach. So it's important to have standardized terminology that can help bring exactness in order for schedulers to have better visibility into the necessary time allocations for what procedures are coming up, and for the system itself to be able to properly calculate that out. So surgeries that have multiple procedures, this becomes really, really important for, because those are extremely difficult to model, because they may be difficult to segment into homogeneous groups, and because they are performed less frequently than single procedure surgeries. And the systems often have difficulty calculating out what the average time of those is from previous procedures. So to dive a little bit more into this example of lymphadenectomy to kind of illustrate what I'm trying to say here. So in this situation, we can see that our theoretical OR performs 30 lymphadenectomies a month. Now, there are 5 different variations of lymphadenectomy that they can perform based on the location. We have axilla, hilar, other, neck, and pelvis. However, since they are scheduling all of these procedures just with the umbrella term of lymphadenectomy, it is averaging together the times of all of these procedures into one, meaning that the procedure time averaging metric being produced by the EHR is 180 minutes, despite the fact that if it's being done at the axilla, it's 120 minutes, or if it's done at the pelvis, it's 240 minutes. For each one of these cases, the system is going to give them the exact same procedure time. It's also going to be using the same preference card, which can lead to ROR waste and supply waste. So what can we do here? Well, we can take this term of lymphadenectomy and we could break it down to more specific procedures. So we can see here what happens with the case duration accuracy as we go to do that. So starting with the axilla procedure. So this procedure done 5 times a month at 120 minutes. Prior to us breaking this down, every time we did that procedure for those 5 times, the system believed it would take 180 minutes and scheduled it as 180 minutes. After we break that down, we now recover 300 minutes in total across those 5 procedures that we're no longer scheduling over. That lets us maybe put another case in there, spread that time around, maybe send our OR staff home a little bit earlier that day. On the flip side, for the pelvis, which was being chronically underscheduled, that takes 240 minutes. But on the lymphadenectomy side, only 180 minutes, 60 minutes over. We are no longer overscheduling. We are now scheduling this at the appropriate amount of time, and we're no longer going to be pushing back additional cases, creating delays, potentially even creating cancellations. So this can have a direct effect on the financials of a OR system. In the situation we had before breaking down that term lymphadenectomy, we had a case duration accuracy measured out at 20%. We had unplanned OR use, so we were under, we had unplanned OR use of 450 minutes, which at 37 minutes of cost, we're scheduling that inadequate time results in unplanned use of OR time, 37 minutes, 450 minutes, that comes out to $16,000 a month, or almost $200,000 a year. On the flip side of that, scheduling in that excess time results in time that isn't actually getting used in the OR. That's an opportunity cost. So that opportunity cost came out at 7.5 hours in this situation we had before. That can give you a potential cost of $27,000 a month or $324,000 a year. So we can see here about $500,000 a year potentially could be recovered just from this one term of lymphadenectomy being broken down into more appropriate terms. Now, don't get me wrong, we're fully aware that this is a kind of a simplified example and that not all of this time is immediately usable and can immediately result in direct financial gains. We want to use this to illustrate how much opportunity there is, especially when you think about this over the course of your entire procedure file. We've been looking at one term here, but an average procedure file is somewhere between 2,500 and 3,500 terms for most organizations. So you may have up to a few hundred of these terms that can be broken down and that could result in better case duration accuracies, better procedure time predictions for your organization. So to dive in here to a bit of another example, another term that we often see being scheduled that we would think of as a bit of an overly broad term is craniotomy. Generally, a craniotomy precedes many different types of neurosurgical procedures. And without a detailed description of what's about to take place, you can't really properly calculate how long the procedure should take. So to give a bit of an example here too, we have some sample ranges of the time. A craniotomy excision of glomus tumor, let's say on average takes about 210 minutes, while a craniotomy insertion of omnia reservoir and shunt takes 90 minutes. If you were in an organization where both of these procedures were done essentially around the same amount of time, but it was just being scheduled with the term of craniotomy, the procedure would be calculated to take about 150 minutes by the system. So in that case, 150 minutes, if you then did 5 procedures, let's say, where they're all really craniotomy, insertion of omnia reservoir and shunt, 60 minutes of extra time are going to be blocked off per case, or about 300 minutes or 5 hours of wasted OR time. That can calculate out to being about $18,000 at a time cost of $60 a minute. On the flip side of that, if you schedule 5 cases with the same average of 150 minutes, where they're all really craniotomy excision of glomus tumor, that means 60 minutes of extra case time are needed per case. So that's going to result in potentially up to 300 minutes total or 5 hours of unplanned overrun time in your OR that can cause delays in the start time of subsequent cases and potentially even lead to cancellations. And we didn't even factor that into the cost here. One other thing I do want to make sure to briefly touch upon that we kind of introduced, we see a lot in surgical scheduling dictionaries is duplication. Now there are 2 types of duplication in surgical scheduling dictionaries. There is exact name duplication or name match duplication, identical duplication, where the same exact surgery with the same name is present multiple times in the surgical dictionary file. On the other side of things, there's also clinically similar duplication, where 2 procedures clinically represent the same thing in the OR, but have different procedure names. We can see that here with vena cava filter insertion cath lab versus just vena cava filter placement. But both of these can cause very similar problems when it comes to trying to calculate out the case duration accuracy and really just overall data management in the OR. If a procedure is scheduled, if the case is scheduled with different procedures, so if let's say 1 week it is scheduled with one cardioversion and the next week it's scheduled with the other cardioversion, the system is not going to calculate those times together. It's not going to record all the other OR data together as well. It's going to treat those as two separate procedures. So this can cause issues. Let's say most systems and most EMRs have a minimum number of times a surgeon must perform a case before it starts calculating out their average procedure times. If you are splitting those times between multiple different cardioversions or multiple different vena cava filter replacements, it's going to take longer before the system's able to calculate out those average times. And it's only going to be doing it with half the data or a third of the data. And so you're not going to get as accurate of measurements as you possibly could. So on top of breaking down those overly broad terms and getting those to be clinically representative in the OR, like we've been talking about, it's also really important to help make sure that you don't have duplication in your procedure file. This allows you to better record all your OR metrics, including case duration accuracy and procedure time averaging. So I know for the last about 20 minutes or so, I've been talking a lot about case duration accuracy, procedure times, and this is all really at the point of scheduling in the OR. But we know that data flows and data quality is really, really important, not just at the point of scheduling and through pre-op, but through intra-op, charge capture, and really through the entire surgical data process. So I'm now going to turn it over to my buddy Vic from Caresyntax. He's going to dive a little bit deeper into some of the data throughout the rest of the surgical process. So Vic, I'm going to send it your way.
Thank you, Alex. Let me see if I can start sharing the screen now. Sharing. Show. Let's see. Do you have to stop sharing here, Alex?
Yeah, did it change to you when I hit change presenter?
Ah, there we go. Show my screen.
There we go.
You guys see my screen? Perfect. Perfect. Let's do this. Oops, what happened there? How about that? Can you guys still see my screen?
Vic, I do not currently see your screen.
Okay, let's try this again.
Vic, I see it.
You do?
Oh, okay, so it's just me.
Yeah, but you're presenter mode. You're good.
Okay. Very good. So good morning, good afternoon, everybody. My name is Vic. I'm the Chief Product and Marketing Officer here at Caresyntax. I'd love to talk to you a little bit more about data-driven surgery. But before that, just a brief background about myself. I've been here for about 2.5 years now, helping to build out the concept of data-driven surgery. And before coming to Caresyntax, I spent about 3 years at Intuitive Surgical as the VP of Digital, helping to build out the ecosystem around the Da Vinci surgical robot. So learned a lot about data-driven surgery, digital surgery there. Before that, going back to the 2000s, as part of a startup company that we sold to McKesson Health Solutions. So as part of McKesson for a few years, learned a lot about revenue cycle management, about scheduling on the financial side. I ran my own business for a little bit of time before going into Intuitive. But today, we're going to talk a little bit about data-driven surgery, right? So there's data coming in from all these different sources. How do we make sure we're making sense out of it and improving healthcare? Just a little bit of who we are. In terms of Caresyntax as a company, our mission statement is about making surgery safer and smarter by empowering healthcare providers, insurers, and surgeons with data-driven solutions. So we're currently being used in about 2,800 operating rooms. We touch about 3 million surgeries annually, and we have a lot of surgery team users too. Over on the right, we see some of our stakeholders here, right? Investors, customers, partners, folks like the American Board of Surgery, AORN, and people like that. But let's go in and talk a little bit more about how we're tying back to what Alex was talking about, right? So Alex was talking about case length duration, and case length duration is really critically important, but then, case length, you can think about that as wheels in to wheels out, right? But then when you look at wheels out of case one to wheels in of next case, now you're looking at turnover time. You're looking at block utilization. Once again, key efficiency measures to think about and consider. Now you start thinking about clinical measures, things like readmissions, surgical site infections, and range of motion, so on and so forth there. And then finally, you get to your financial measures in terms of cost per case, profitability. So the underlying construct over here, are you guys still seeing my screen or no? Did I lose that?
Yeah.
You are. Okay. Let's see here. The underlying construct over here is really to look at standardized terminology to help standardize these KPIs, right? Because if you don't have standardized terminology, then you're not really comparing apples to apples, but you're comparing apples to oranges here. So let's probe on that and pull on that thread a little bit more and talk about this concept of surgical variability. What do we mean by variability, right? So I'd like to really talk about this one publication by Dr. Sheets and others. And what they did was they took all of the different hospitals that were part of the 2018 US News and World Report Honor Roll, right? So these are highly regarded hospitals and health systems. And each of those health systems are numbered over here, 1 through 16. And they measured the patient complications in each of the hospitals within that health system. So take a look at health system number 16 over here, for instance, right? With health system number 16, there's various different hospitals. The yellow hospitals are the hub hospitals, and the green hospitals are the non-hub affiliated hospitals. When they looked at complication rates, surgical complication rates, it varied all the way from 3% of all the cases having complications to 30% of cases having complications, right? So a lot of variability over here. And we would like to say, let's move the hospitals that have 30% complications closer to the hospitals that have 3% complications. And you're seeing that across all the different highly regarded, highly rated health systems in here. So variability exists, and that's an opportunity for us. The next thing I want to talk about is operating efficiency and operational outcomes. Do we have variability there? Once again, these peer-reviewed publications show that there is variability there, right? So you're looking at, for instance, this particular hospital and the set of health systems, and there was variation from 23 minutes for room turnover all the way up to 60 minutes for room turnover. So once again, you're not comparing like a small lap chole case to a radical prostatectomy case. You're comparing like cases here, so you're seeing variability. Variability also exists when you're looking at costs. This last slide over here at the bottom right, it's talking about the cost ratio between the lowest cost hospitals and the highest cost hospitals. And they were looking at common procedures like colectomy, CABG, TKA, total knee arthroplasty with a replacement, cesarean section, and things like that. And they found that there's a lot of variability there. 15x difference in colectomy costs between the lowest and the highest hospitals, all the way up to 25x when you're looking at cesarean section. So there is variability in here. So what do we do about that? So the approach that we talk about from a data-driven surgery perspective is to really differentiate between what we call unnecessary variation and necessary variation, right? So when you have patients who need different kinds of procedures like Alex was talking about, when there's a craniotomy with differences with excision of tumors versus something that requires an OMI reservoir, that's a necessary variation because that's where you're saying, hey, look, there's a different disease condition and presentation. But for the exact same procedure, do we need to have different instrument sets? Do we need to have different ways of setting up the OR? That would be unnecessary variation, right? So I really like this quote from Dr. Paul Rothman, who said, technology serves to get the unnecessary variation out, while the physician is there to keep the needed variation in healthcare. So an approach using data-driven surgery to remove this unnecessary variation could be to say, first establish that initial baseline for your clinical, operational, and financial KPIs. And not just what I call as the tyranny of averages, right? So I like to use the example of, I've got two dogs. One of them is a 7-pound Chihuahua, the other is a 70-pound mutt. The average is 38 pounds, but I don't think I'm going to go out and say I have two 38-pound dogs, right? You're going to have one that's small, one that's large. So you need to kind of look at your inliers and your outliers and look at your distribution, not just your averages. So we need to be able to optimize that entire population. But once you establish the initial population, we want to make sure that we can change that entire program. And that's where we say, hey, look, let's look at seeing if we can increase the median values for everybody, right? So you're kind of making sure that you have a rising tide that floats all boats here, and you're reducing variability and reducing standard deviation. So you're saying, look, let's make sure that you're not seeing a variation of 15x in cost. You're not seeing a variation of 30% to 3%, but maybe you're still going to see a variation, but maybe it's a variation of complications between 3% and 10% as opposed to 30%. So how can we reduce those standard deviations? So that's really the approach that we'd like to talk about in terms of data-driven surgery. Now, once we have this approach to reduce unnecessary variation, we can talk about how we go about it. But I think this might be a good time to see, where are you folks seeing variation, unnecessary variation more specifically? Is it around your operations, right? Is it around your case length duration, your turnover times, your supply costs? Or is it really around your clinical outcomes in terms of your readmissions and your length of stays and infection rates? Or is it really around your financial components in here? So I'd love to kind of get your thoughts on that.
Give it a few more seconds, Vic.
Yeah.
All right, gonna go ahead and close out.
Let's see. I'm having some technical difficulty over here, Jordan. I'm not seeing the results over here.
So it looks about 67% said operational efficiency, 25% said clinical outcomes, and then the rest said other.
Okay, perfect. So I think that definitely makes sense. Sounds like we have now more than 2/3 of this operational variability really being the question and the concern, and that does make sense in terms of everything else that we have heard from our partners in terms of what they're seeing there. And I think one of the things we're going to do is do a little bit of drill down and looking at that variability and saying, what could be some approaches that you could use to reduce that operational variability? So thank you very much for those responses there. Let's go ahead and take a look at some potential options over here to reduce that unwarranted variation and improving outcomes on all of those components there. So when you think about data-driven surgery, right, we need to figure out, where are we getting the data from? And the data spans that entire surgical pathway. You're looking at pre-op, intra-op, and the post-op perspectives. From a pre-op perspective, you're looking at imaging, patient risk factors. From an intraoperative standpoint, you're looking at device implant information, imaging, also video, right? So video is going to be really crucial to understanding what is exactly happening in the operating room, and then combine that with electronic health record data, vitals, and other components. And then from a post-op standpoint, look at length of hospital stay, readmission rates. You combine all of that into what we call as the high fidelity surgical record, right? Which understands exactly what happened inside the operating room, because that's usually seen as something that's very opaque today. You then compare that with what the clinicians and the surgical teams really wanted to happen, right? That's what we call as their personalized surgical playbook. All clinical teams have this construct of what best practices are objectively, what preferences are that they would like to see. When we compare the high fidelity surgical record with the personalized surgical playbook, that's really when you start looking at variability and you define, well, where are there opportunities to help improve? How can you improve patient outcomes, reduce complications, improve proficiency? From an operating efficiency standpoint, how do you start looking at case length, turnover times, and then improving profitability? So that's really kind of that high-level approach about data-driven surgery to reduce unnecessary variation, but really focusing on that high-fidelity surgical record and then identifying variation. Now, once again, we need to be systematic about how we go about it, right? So the first step is to identify the variability and say, let's look at big bodies of data and identify where are the inliers and outliers, not just look at the tyranny of averages. So that's what you start with first. But once you identify the variability, a lot of times, sometimes the question might be, the reason might be obvious, and you say, of course, now that we have shed light and identified what the problem is, we know what the solution is. Oftentimes, it's not as obvious. That's when you have to start investigating those cases and trying to diagnose the problem, understand the root cause analysis. That's when you start looking not just at what's in your electronic health record, but you may want to start looking at operating room video. You may want to look at surgical video coming in from your laparoscopy towers, or from your echo if it's a cardiovascular case, or from your imaging data and your navigation data if it's an orthopedic case in here. So now you start understanding what exactly was happening in there. Once you've done that, the next step is to identify how you can implement change. Implementing change oftentimes can be best practices, training modules, making sure that you have decision support tools in there. And then finally, how do you start sustaining change on an ongoing basis? Because it's not just enough to implement change and say, okay, now we're done. We need to make sure we're doing it on a daily basis there. So this is really kind of the more common sense approach from a data-driven perspective about how you're thinking about implementing change and managing change on an ongoing basis. So with that, let's go a little deeper into preoperative efficiency, because this ties in perfectly with what the audience was talking about in terms of knowing that there's a lot of variability in their operational KPIs. It's almost like this was scripted. Interesting. So it was not, but I'm glad that we aligned there. So we noticed that the operational KPIs are highly variable as some of the challenges that we're seeing over and over. We're also seeing that there's a desire to move all of those operating rooms towards the higher quartile. Another important conversation that's happening is how a lot of hospitals are having trouble with retaining their OR staff, bringing in new staff, and oftentimes they're augmenting them with travel nurses who may not be as familiar with the surgeon's best practice and preferences. So you're seeing issues with workflow in there, and that could be contributing to some of the reasons why you're having longer case lengths, even after you've made sure that you're doing apples to apples comparison in the ways that Alex spoke about, and also the other ways that we spoke about looking at variability. We've also heard a lot about utilization problems, right? So Alex spoke about how every minute of the OR is either somewhere around $37 per minute, $60 per minute, all the way up to $200 per minute. If you don't have effective utilization management in here, you're looking at significant overtime costs and some patient dissatisfaction. Sublining plan costs. Once again, is it necessary variation or unnecessary variation? How do you make sure that you can identify what's unnecessary variation, which is, once again, a conversation, which is a data-driven conversation you want to have with the surgeons, with the clinical teams, and make sure that we're doing the right things by the patients, the surgeons, and the staff in here. So how do we start looking at variability, and how do you start moving all of these towards the highest quartiles? So given these are some of the challenges over here, what could be some approaches using this concept of the high fidelity record we spoke about, the concept of these personalized surgical playbooks, looking at variability. So here's some approaches and some potential constructs over here. So when you're talking about enhancing your workflow, some of the KPIs you're going to be looking at obviously are case length, right? So we talked about case length with Alex, but can you also start quantifying teamwork dynamics? That's where we have a new KPI called the NOTS score, NOTSS, these are non-technical skills. And these look at things like teamwork dynamics, situational awareness, communication with the OR staff and the surgeon. So you're quantifying teamwork dynamics and giving that a score of 0 to 4. And now, can we start looking at that and saying, is there variability? Can you start looking at that? Can you start looking at case length, case volume, on-time starts, room turnovers, or utilization of these constructs in here too? So to optimize these kind of KPIs, first of all, you start with a cohort analysis, looking at this, doing the apples to apples comparison. You identify the right terminology, but also you make sure that you're risk adjusting based upon the case stack, your risk adjusting based upon the patient severity and the patient demographics. And now you start comparing and then saying, where's the variability in there? You start looking at this concept of this personalized surgical playbook and say, look, all the surgeons, all clinical teams have the best practices. How do you make sure that it's not living just in their head, but can you bring that in a digital format? Can you leverage video to do these constructs? Because once again, video never lies, right? So you need to make sure that you're working through that. And then now can you do the reviews and compare what was actually happening with what you think was happening, and then can you come up with some good ways of identifying some improvements. So really enhancing those workflows using those interventions is a great idea. Next, let's take a look at improving utilization with data-driven surgery. So the KPI that you're going to look at this point is going to be around prime time utilization, right? But one of the interesting constructs of utilization is how we actually manage that with block time, right? So once again, I'm preaching to the core. We're here with a lot of you folks coming in from that background, but block time is great because it gives a level of predictability to the surgeon schedule. They can say, I'm going to operate on Mondays and Wednesdays. I'm going to do clinic on Tuesdays, overflow on Thursdays, and things like that. However, it makes it a little less dynamic, a little more static in terms of how scheduling could actually happen. Now, there's a lot of situations where automatic block release times typically are somewhere in the 48 to 72-hour range, right? So that's when the automatic block release happens. However, we know that Dr. Smith typically schedules the cases 3 weeks out in advance. And if they've not scheduled their case when it's 3 weeks out, could we send them a nudge electronically and say, hey, Dr. Smith, you typically schedule your cases 3 weeks out or 4 weeks out in advance, and you haven't done that yet. Well, is there a case in the wings that you would just want to make sure you can schedule, or would you like to release that? So now all of a sudden, you're creating more capacity in the system by saying, hey, look, let's see if you can release that faster. Once you release that, you've created more capacity. The next step is to proactively inform surgeons about this new open time and say, hey, look, we now have new block time available 3 weeks out on Mondays from 7 a.m. to 2 p.m., prime time that's opened up over here. Can you make sure you can look at your schedules? Can you leverage that, right? Of course, you want to make sure that this targeted. You're not going to be sending this to everybody, but you might want to send this only to people who are in the ortho line or the oncology suite or however the case might be. Also, you want to make sure that you're providing visibility and transparency into what that block time looks like. So Dr. Smith says, hey, look, I've got this inguinal hernia patient and a healthy 23-year-old male who actually got this from going to the gym. I can fit him in next Tuesday. Let me go and see if I can find that availability. Can you do some dynamic searching and looking to make sure that you're providing the transparency? Think of this as, open table for the block time, right? So open table does a really good job of providing this level of dynamic scheduling functionality for restaurants. Can we start doing that for operating rooms so that you can open up capacity and make sure that you're doing more surgery as you're improving utilization? So once again, a very data-driven way to start doing this, but also using behavioral economics constructs in here so that you're doing nudges as opposed to laying down the law and changing some policies in a more drastic fashion. And then finally, let's take a look at supply and implant costs using data-driven surgery, right? So once again, we want to look at unnecessary variation, not the necessary variation. But we're not here to say, hey, Dr. Smith, you need to be changing how you do your surgery, and other surgeons are using 3 instruments, why are you using 4? You give them the data. You give them the data to say, hey, Dr. Smith, looks like other surgeons are using 3 instruments in almost the exact same kind of cases that you're doing. Does this make sense? Is there anything that's different that you'd like to look at? And then you have the conversations where you might say, well, looks like you need to have this other 4th instrument only in 10% of your cases. Could we put that in a blue peel pack and put that out in the core so you have it available to you, but it's not part of your normal instrument tray pack? So you have those conversations with data, find the inliers, the outliers, and export the whole thing by cohorts. And now you have a much deeper conversation as opposed to saying, hey, look, my patients are different. I just need to have all 7 instruments in my instrument tray. I don't care how. So using data to try and create these lean trays with data-driven surgery is this third component of how you might want to try and reduce variability. So hopefully these strategies have been useful to all of you folks who have been spending your time over here listening to this. But want to leave you folks with some case studies that we have seen over here. So we looked at about 2.5 million cases from 77 facilities using our platform. And this is where we found that there was some very interesting information. We have found that using data-driven surgery approaches like what you just heard, you can start reducing room turnover by about 4%. You can increase your first case starts. You can increase your block utilization by about 12%. And really increase case volume overall by about 5%, resulting in about 20,000 per OR per month. All of this is kind of newfound operating capacity without having to build new operating rooms. Another interesting case study is going more to that clinical construct and patient safety in addition to efficiency. So it's combining all these different constructs. So University of Iowa was able to use this construct of data-driven surgery to identify where they have variability in surgical care, and they found that there was variability with surgical site infections, pressure injuries and ulcerations, and room readiness. So there was actually a lot of different opportunities that were identified, and the change implementation really came out from increasing training and increasing a little bit more mentoring, proctoring, and then sustaining that change on an ongoing basis to make sure that those changes are something that's sustained. And Dr. John Cromwell, who's the clinical professor of surgery, minimally invasive and bariatric surgery, he does a lot of colorectal surgeries. We talked about how technical skills, teamwork skills are two very necessary components. And one of the biggest challenges is to make sure that you can get that highly granular data so that you can drive clinical and operational improvements. So I believe that was our last slide over there. And we should now be open to some questions and answers here. Jordan, back to you.
Awesome, thanks, Vic. Yeah, so if you don't mind entering your questions into the question panel and we'll get started. But there are a few questions that came in. So this one is for Alex. Does IMO have terms for all conceivable procedures?
So we have about 75,000 plus procedure terms in our overall data warehouse and our surgical scheduling dictionary. We don't anticipate any organization, of course, using 70,000, 75,000 procedure terms. We find the sweet spot for most organizations to be about 2,500 to 3,500. We do occasionally still come across situations in which an organization does a procedure that we've never seen before. Maybe they invent a new procedure. In that case, we work with them in order to come up with a term that fits them and help make sure that they get all the appropriate CPT codes. Within our list too, I do want to call out that we also have worked on our product for surgical scheduling with AORN, the Association of Perioperative Registered Nurses. I think some of our friends from there are on right now. And so we also incorporate the procedures from their AORN's integrity procedure list, which really help represent some of the best practices in surgical scheduling. So we have a lot of coverage to answer that question.
Awesome. And then this one's for Vic. How can we better be prepared to deal with surgical staffing challenges such as staff shortages and increased turnover?
Yeah, no, I think that's a great question, Jordan. So I think the first step is once again to understand what's really needed in terms of staffing, right? So we like to use a KPI called concurrent utilization, where we can look at historical information and say, how many rooms do we really need to run concurrently at the same time, right? So you may have an operating suite with about 15 ORs, but do you really need to staff all 15 ORs at the same time? By looking at this kind of trend information, you can then say, hey, look, let's make sure that we can identify if you need to run all 15 ORs, or maybe it's only 7 ORs that you need to run for your prime time from 7 a.m. to 2 p.m. And then after that, maybe you run only 3 ORs, and that's going to be good enough, and you don't have to have overtime costs that you kind of build in. So understanding what the true needs are as opposed to kind of the aspirations, I think is going to be one key component, so you can adequately understand what are the true staffing needs in there. And you can start making predictions about how we can kind of start moving forward beyond that. But I think more broadly, we've also found that there's a lot of opportunities to help health systems onboard much more quickly, right? So we talked about how there was some hospitals that we've talked to that said 47% of all of our OR staff positions are currently open. They're still recruiting. They're filling some of those with travel nurses. So when you have travel nurses come in who don't understand Dr. Smith's procedures as well, and then they may know general surgery broadly, but they may not know exactly how Dr. Smith does the robotic procedure or the lap chole procedure. So can we use video to make sure that you can onboard them much more quickly? Can you make sure that we can capture these personal preferences and make sure that they can come up to speed much more quickly? So doing those kind of interventions to implement change and then sustaining that change on an ongoing basis could be some great ways to look at that. So that's really what comes to mind initially. Great question.
Awesome, thanks, Vic. All right, another question for you, Alex. Do you help organizations calculate their current case duration accuracy?
Yeah, absolutely. So with the right data, we can help, calculate that out with a lot of different organizations. That's something we've definitely done in the past. We can also help try to tie that to, financial metrics for your organization. And then outside of case duration accuracy, we can also do a lot of analysis. We can analyze the procedure list, kind of give you a sense of where you're at right now, and kind of an understanding of where you may have some shortcomings and where there's going to be some room for improvement.
Awesome. All right, Vic, last question. Do you have a specific example of how hospitals are gaining insight to improve OR efficiencies?
Yeah, so that's a really good question there. Now, one of the things we talked about is this concept of the high fidelity record, right? So you can capture, for instance, what the turnover times are. Excuse me. But oftentimes, you may not be able to go deeper than that. So for instance, you notice that the surgeon turnover, right? So the time between the close of surgery number one to cut of the next surgery, that's getting longer. But why is it getting longer? Is it because you don't have the surgeon coming in on time? Is it because you have problems with intubation? Is it a problem with patient preparation? So those are all some interesting questions to ask and answer. And when we have OR video, which can be, once again, de-identified, be part of a patient safety organization, you make sure that it's a safe learning environment, you may find out that there's an enormous amount of time being spent on patient positioning, for instance, right? So everything that happens between the patient entering the room to the first cut happening, right? Patient positioning, intubation, inserting the ports. So are there some workflow constructs there that need to be improved, or some specific things that people have been looking at? And those are exactly some constructs we have found. So certain kinds of surgeries where patient positioning takes an enormous amount of time, and that's one of the main reasons why the time between patient entering the room to the first cut takes a much longer time. So optimizing those is now providing some new insights which we never had before, right? So you could identify wheels out, wheels in, cut, close, but we couldn't really look at intubation. We couldn't really look at patient positioning. We couldn't really look at instrument exchanges. And so now we have an option to look at those kind of metrics and interventions and events in there too. And that's really changing the dynamic of how we can optimize in there.
Awesome, thank you. All right, I think we're gonna wrap it up. Thank you so much, Alex and Vic, for an awesome presentation. We hope you found today's information valuable. Be on the lookout for a follow-up email that will include the recording and contact information for both Alex and Vic. Thanks so much for attending, and have a great rest of your day.
Thanks, everybody.
Thanks, guys.